Welcome back, Super GPs. In this lesson, we're going to cover the two forms of supplemental anesthesia you may need in order to achieve profound anesthesia for invasive dental procedures. The first is an intraligamentary injection, and the second is intrapulpal anesthesia. Both are very easy techniques and super effective when needed, which is by no means the majority of the time. Usually it's for hot teeth, most commonly hot lower molars. Intraligamentary injections, or sometimes called PDL injections, are given if your initial forms of anesthesia are not enough, or if your patient is still feeling the cold when you do your cold test verification. Intrapulpal anesthesia is given if you and your patient think you've reached profound anesthesia, but early in an endodontic procedure, they still have discomfort. Intrapulpal anesthesia is given with the rubber dam on and were in fact needed in 2 of the live case demos in the 90-day Super GP course. For your convenience and because I like you, I've included those situations in this world for your viewing pleasure. So without further ado, let's head into the operatory. All right, friends, so we're already given our mandibular block in an attempt to numb our patient's tooth number 19, but he still has some sensation to cold. This is when you want to whip out your intraligamentary or PDL injections. Again, Septicaine is the way to go for these situations when epinephrine is not contraindicated. Bend a 30 gauge needle approximately 45 degrees and place it interproximally. You'll want to get that needle deep into the periodontal space. If you're in the right position, it should require a lot of force on the thumb ring of the syringe to deposit the anesthetic solution. It may take 20 to 30 seconds to get enough anesthetic in the tissues to cause blanching, but that's ideally what you're looking for. You should achieve this with a minimal amount of anesthetic. Once you have blanching, take out the needle and repeat this process around the buccal and finally to the other interproximal areas of the tooth. You almost never need to perform this on the palatal or lingual surfaces to get the job done. 3 to 4 sites should cause considerable blanching of the tissues and should only require about half of a cartridge of anesthetic. Let that settle in for 30 seconds to a minute and then check for profound anesthesia again with your cold test.
So once you have visualization of the pulp, then you have the opportunity to give your intrapulpal if your patient still has any discomfort. So you take your 30 gauge needle bent at 90 degrees and you insert it directly into the pulp tissue. The patient will feel it for just a second and then you quickly deposit as much anesthetic as you can to get them anesthetized. And in this example, as soon as we got access to the pulp, we went ahead and poked around with our Endo Explorer only to find that the patient was jumping. So you can see they felt that a little bit. So what you're gonna do is you're gonna take your Septicaine on your 30 gauge short needle, you're gonna bend it at 90 degrees, and you're gonna insert it directly into the pulp. You can't do this technique if the pulp isn't exposed. So you have to have direct access to the pulp. But as soon as you insert it, the patient will feel it for just a second, and then you're going to deposit anywhere between 1/4 to 1/3 of your cartridge of anesthetic, and this is going to get them 100% numb. Make sure they know that you only got them to 99%, and now we're going to get them to 100% with this technique.
All right, Power Up Endo Nation, there you have it. These supplemental anesthetic techniques are there for you, and the vast majority of the time will bail you out so you can perform your planned procedure. I'm gonna be honest with you as usual though, there's always that one case a year where no matter what you do, the patient will not get to a deep enough level of anesthesia. Could this be due to anxiety? Who knows? But either way, it's not worth trying to convince your patient to struggle through the procedure. In these scenarios, which again, should only be literally 1 in 1,000 cases, I'd recommend you reappoint this patient for a later day and have them take 600 milligrams of ibuprofen along with 1,000 milligrams of Tylenol 30 to 60 minutes before their planned procedure, assuming no contraindications, of course. I have found that doing so, in addition to letting them know this is their last chance to save their tooth, will lower their pain threshold enough to achieve profound anesthesia using these same exact techniques. I hope you found a ton of value in these live demos and are ready to provide bulletproof anesthesia in your practice. Bye now.